we're gonna cover today is, kind of things to watch for on the test and on the registry. So and some of the things that you'll see in the textbook. And I know y'all are studying the textbook just word for word, right?
Oh, yeah.
Of course, yeah. It still crackles when you open it, right? So, remember that in our foot, we have different words for, anterior and posterior portions. It's a little bit unique. Anterior portion is the dorsal portion, and the plantar portion is the bottom of the foot, like you plant your foot, means you put your foot down if you've ever played basketball or anything like that. You plant your pivot foot, and you can't pick it back up. That's the bottom of your foot. It's plantar surface. So in our toes, we're going to use a 15 degrees cephalic angulation. In our feet, we're going to use 10 degrees. So make sure that you don't confuse those two. It's 15 degrees for the toes and 10 degrees for the feet. So also on our obliques, we've got some specific things to remember on our obliques as well. So you'll see that in the obliques, especially the foot, not so much of the toes, but in the foot, you'll see a 30 to a 45 degree angulation, and that's a pretty broad range. I think Merrill's just says 45 degree angulation, but it can be as low as 30 degrees. So the difference between those is whether or not the patient's flat-footed. Steeper angulation for high arches, and if you're doing a foot, again, not so much for the toes, just go ahead and do like 45 degrees for toes. But if you're doing a foot, then take a look at the shape of the foot. We tend to take a look at the bottom of the foot and determine flat-footedness off of the bottom of the foot. Logically, that's kind of where it should be, right? But what you'll find is that some people have a flat bottom of the foot, but they've still got a very steep arch, or they've got a steep arch causing a pretty good wedge shape of the foot. In the book, they show the same model demonstrating flat-footedness, and all they're really doing is applying pressure to the foot to kind of lower that arch a little bit. So what you have in some patients is if they've had some lower extremity trauma over time, then what they may suffer from is what we refer to as fallen arches. So the tissue that should be following the shape of that arch doesn't anymore. So the ligaments are kind of stretched out and they kind of sag a little bit. And that leads to plantar fasciitis, which is just a soft tissue issue. And it usually occurs, again, because of, maybe somebody twists their ankle one too many times in their life. And just things get stretched out. They don't follow the contour of the foot anymore. If you find yourself in later in life, you probably aren't having any kind of problems with it right now. But if you tend to suffer from plantar fasciitis later in life, arch supports are the key. I carry, my maladies. I've always got something. I carry some around with me all the time. These are just bandages, go right around the arch of the foot. If you ever see me walking, I just stop dead and take my shoe off. It's because it just hit. And if I put one of these on, 2 steps later, I'm perfectly fine. So keep that in mind. Wrap around arch supports are the way to go. So you've got the AP, you got the oblique. The oblique's 30 to 45 degrees depending on the arch. High number, high arch, and then your lateral. So I want you to keep in mind on each one of your laterals of the lower extremity, that being the lateral of the foot, the lateral of the ankle, and the lateral of the calcaneus. You may run into some questions that asks which lateral consistently provides the best, lateral projection or visualization. And the answer is kind of counterintuitive, and it's opposite of what you almost always do. And this is just a test thing. It's not so much, look at this guy's toes. He's got some problems. I probably should have pulled the other one. That toe's twisted all the way around. But what the
medial lateral projection gives you that the lateral medial projection does not is a couple of things. All right, so the answer to that question, if you run into the question, which lateral consistently provides better lateral projection, is with medial side down. Okay, so you usually shoot with lateral side down because it's easier to get the patient into that position, but medial side down consistently gives you better lateral, okay? And that's for a couple of different reasons. The most significant of which is that if you look at your foot, the surfaces, the medial surface is much more broad than the lateral surface. So how many times have you done a lateral foot that you put the foot on the image receptor and they had a tendency to kind of, the sole of the foot was pointing up a little bit, so that they were in rotation, right? So that you had to go back in and reposition the patient's foot so that their metatarsals and phalanges were superimposed. If you have, if you have them on the medial surface, then that broader surface, you're less likely to have that issue. Okay, so that's number one. Number two is that if you look at the foot, the first toe in the first metatarsal is going to be the fattest one, right? So if you put the fattest anatomy furthest away from the image receptor, then you're going to be magnifying the fattest anatomy, right? So if you put it closer to the image receptor, you have less magnification. So for those two reasons, you get more consistently a better lateral with a medial side down. But it's kind of hard to get the patient into that position. What you're going to have to do is have the patient up on their side and their knee in contact with the tabletop to get them into that position. May be very uncomfortable for the patient. But remember that for the test, all the way through the registry, medial side down, more consistent, good lateral position. For toes, it's a little bit different. With toes, what we're going to do is whichever toe the patient's hurting, or whichever toe hurts on the patient, that's what side we're going to put down. Right, so if their trauma was on the medial side, you put the medial side down. If trauma's on the lateral side, which most of the time in my experience, that's where the damage is. Somebody gets up and they kick something real hard in the middle of the night and, they break a toe. Right, so in that case, it'd be the lateral side down. Also, sometimes going back to ankle trauma, if a patient twists their ankle bad enough, you may wind up with a fracture of the proximal fifth metatarsal. Okay, and sometimes I won't say it's an incidental finding because it happened because of the rolling of the ankle, but it's an avulsion fracture. It's what we refer to as a pseudo-Jones fracture. So Jones fracture, we've seen Jones fracture a couple of different times, and that's a fracture of the base of the fifth metatarsal. And we've got three different levels of Jones fracture. Pseudo-Jones fracture is basically an avulsion fracture of just that tubercle right there, and then we've got two different levels of Jones fractures that are a little bit distal to that. So the takeaway from this slide, was 15 degrees cephalic angulation for toes. Which toe depends on which lateral, or the lateral that you shoot depends on which toe hurts. Your oblique is always going to be internal oblique. When you internally oblique your patient, you're going to have a tendency to tell the patient to just move their knee in, and look how much motion you get just by moving the knee, right? And the foot doesn't move at all. So watch the patient and have them move and make sure that the lateral side of the foot comes up, okay? So the other thing of note for toes that is different from fingers is everywhere that I've ever worked, we never did a single toe. We did all toes. And that's primarily because it's a little bit more difficult to pinpoint exactly where the pain is in the toes, right? You kick something, let's say just with the side of your foot, you bump into something pretty hard and the entire side of your foot hurts, right? So you can't say it hurts right there. So as a result, for the most part, when you do toes, and this is my personal experience, every hospital I've ever worked in, we did all toes rather than individual toes. Okay? And because of all of the superimposition that you get in feet and toes, with all that, all those bones put on top of each other. The lateral, it's difficult to get a diagnosis off of a lateral, and we're going to take a look at that here in a little bit. So sometimes oblique becomes more significant than the lateral to determine anterior to posterior displacement and fracture. So you might want to keep that in mind. If you get an order for a 2-view foot and you can't see, you know that there's a fracture there because you saw it on the AP, but you can't really see it on a lateral, you might shoot oblique. Just add oblique in order to fully demonstrate the fracture. Okay. So evaluation is similar to fingers, so we're not really going to walk through that all that much. We're going to look at the concavity versus convexity, soft tissue, anterior, posterior, make sure the toes are separated. If at all possible, it's a little bit more difficult to separate the toes as opposed to the fingers. Where our central ray is going to be located in this case, and again, another difference between fingers and toes is that we're going to put our central ray perpendicular to the metacarpal phalangeal joint rather than the interphalangeal joint. So we're going to include about half of the metatarsal, and the toenail, the book says you can evaluate rotation using the toenail. Have you seen feet? And I say these toes look pretty bad, but that looks like most of my patients, that had toe issues, So, toenail's not very accurate, especially on the lateral side. That fifth toenail may be really on sideways, so you really can't use the toenail that well. So, if you don't angle the central ray, you're going to get closed joint spaces. It looks like we've actually got some quantum model on this one. That's kind of cool. Keep in mind we've got sesamoid bones under the first toe. I'm going to scroll back up here in a second and show you all the different places we can have sesamoid bones on the lower extremity, and there's a lot of them. And the sesamoid bone may be because of trauma. You may wind up with a slight avulsion off of maybe like on the back side of the ankle, maybe off the distal portion of the talus, and it just kind of stays there. Or it could be just a formed sesamoid bone. So what we have here, it almost looks like that's pretty smooth, but it could be a sesamoid bone fracture here, and that would be what you refer to as turf toe. So where you run into things like that would be in patients who have high impact, continuous, runners, football players, ballerinas, things like that. They'll break those little sesamoid bones, and they can be very, very painful. So scrolling back up to this, some of this is anatomy, and some of it is just accessory sesamoid bones. And you see one behind the ankle, and if you look at this x-ray, every one of the metatarsal phalangeal joints, distal portion of metatarsals, have sesamoid bones. So some people just grow them. It's kind of odd, but some people just grow sesamoid bones. This one is a fracture. Again, we've got turf toe there. All right. So just positioning looks like that. If you know which toe is potentially broken, you might want to take the rest of them back in order to get a good lateral. But again, the oblique may be your better projection. If a patient has potentially multiple toe involvement, that's just not going to do you any good at all. So our feet, again, we're going to back our angulation down to 10 degrees, 50 to 65 kVp. Compensating filter, I think this is still a registry testable thing, even though you probably don't see compensating filters in clinicals anymore. But because the foot is such a wedge shape, in traditional radiography with screens and films, we would use a compensating filter, or we would have to shoot for the anatomy of interest. In other words, if a patient, if we got an order for a foot, but they complained of pain more down towards the distal portion of the metatarsals, we would shoot with a totally different technique than if they drop something heavy across the forefoot, across the proximal portion of the foot. So with a wedge filter, we could actually visualize from toes to all the way back to as much of the foot as you can actually see. Once you get into the ankle area, it's kind of difficult to see through all that tissue, right? So wedge filter helped out with that, but now with DR processing, it kind of ferrets out that intensity difference or that density difference. So wedge filters are really kind of a thing of the past. So shoot for where the pain is. Interphalangeal joints should be open, no rotation. All the things that we looked at before, and even in hands, we're going to look at all those same things. Toenail, lesser than everything else. All your joint spaces should be open. Your interphalangeal and your metatarsal phalangeal joint spaces should be open. And especially on the medial side of the foot, once we rotate up into our oblique, we're going to open up the joint spaces on the lateral side of the foot. Okay, so AP of the foot, again, you just don't see the proximal portion of the foot, the calcaneus, all that well because of the talus superimposed on the distal portion of the tib fib. So when you shoot, your foot, probably one of the more common fractures I've seen has involved the fifth metatarsal. So Jones fracture, we'll again take a look at that, and that there's 3 different lines starting right about here. And the pseudo-Jones fracture is an avulsion of the proximal portion. So when you're doing your lateral of an ankle, let's say, try to include enough of the foot so that we can take a look at that proximal portion of the fifth metatarsal. So this is the difference between, this is back in screens and films, this is the difference between shooting with and without a wedge filter. Oops. So again, if a patient had pain in the toes, the distal portion of the metatarsals, we'd have to shoot with a totally different technique. You just can't even see the toes there, right? As opposed to, you can see the forefoot really well, but if you used a wedge filter, you can see the whole thing. And this looks a little bit more, I mean, your DR images are even better than this, but it looks a little more like a DR image. So your oblique of the foot, we already talked about that, 30 to 45 degree internal rotation, make sure the lateral side of the foot elevates. And shallow arch, 30 degrees, high arch, 45 degrees, and judge that, again, based on the shape of the foot. You know, if the entire foot looks like a pancake, they're flat-footed. If it's still got a good wedge shape to it, even though the bottom is flat, then chances are that's all soft tissue. That's just fallen arches, so to speak. The bones don't actually sag. But you see what they did here. You've got a little bit of an arch here, and then they brought the leg up and mashed down to try to flatten that arch out somewhat. So our medial oblique, what we're going to be looking at is the bones on the lateral side of the foot should open up. So we're going to have increased superimposition on the medial side. So let me get down here in the white portion. As we rotate up, try to get this back so that hopefully y'all can see it. As we rotate up, notice we get more superimposition on the medial side and the lateral side opens up. And you get this nice space all the way, it should be seen all the way around the cuboid, right there. Okay, so medial oblique, always medial oblique on your feet. So if you over-rotate, then you're gonna have your navicular superimposing cuboid, the increased superimposition on the medial metatarsals as well. So that's what we're seeing. That's your navicular, and so if we over oblique, we're going to start to close that joint space right there. So good oblique should show us a joint space all the way around the cuboid. We should be able to see the separation between the third and the fourth, and the fourth and the fifth metatarsals. So lateral foot, we're going to have to increase our KVP or increase our mass from the AP. Again, which one is better and why? Well,
context here is because of the broad base, or the broad side of the medial side, then it's better to put it on the medial side. Realistically, you're probably not gonna do that unless you're shooting cross table, or if you just wanted to see the difference between the two, but it really does make a better image. If you're gonna shoot with lateral side down, I highly recommend that you dorsiflex the foot to 90 degrees. And what that does is, because when the patient, just, you know, if their toes are pointed at all, that's where you get that little bit of supination. Okay, so what I mean by supination is the plantar portion of the foot rotates upward just a little bit, so that you don't get a good lateral, right? But if you dorsiflex a foot, it has to 90 degrees, it has a tendency to pull the foot into a more true lateral position. Okay, probably one of the most under-focused on things on the lower extremity is dorsiflexion of the foot on the lateral foot. Okay, you just kind of put your foot up there, and next thing you know, it comes out and it looks like that. All right, dorsiflex foot, and it'll look more like that. All right, so that's what it should look like. Note still that we don't have perfect superimposition, but that's a pretty good lateral foot. Maybe a little bit of bone spur there. Sesamoid bones, don't visualize them all that well. But, you know, the fundamental difference between lateral foot, lateral calcaneus, lateral ankle is central ray location collimation. You know, they're all positioned exactly the same. So we're not gonna stop on each one of those and talk about all the particulars of all of them. Fair enough?
Mm-hmm.
So even on this one, if you notice, the toes are, you know, we're starting to get a little bit of supination there, even though they're at 90 degrees. So this one Josh sent, let me magnify each one of these. Sometimes it doesn't want to cooperate all that well. So lateral, ignoring the AP and the oblique, looking at the lateral, aside from a pretty nasty moire artifact there, do you see anything wrong with that foot? I don't mean positioning, collimation, I just mean do you see anything wrong with the foot itself? The answer is no, you don't. But if I magnify this guy up, now do you see anything?
Mm-hmm.
I assume this is the same person. Yeah. So you see what I mean? The lateral sometimes just doesn't give you the information that you need to see, as opposed to an oblique. And not to, you know, really criticize or anything. This was what I was talking about in guarding against, you know, just having the patient move their knee over. It's not oblique much, but you can still see, you know, it highlights that fracture a little bit better. So sometimes that oblique is a better view than the lateral to visualize a fracture. So, you know, if you have a good rapport with your ER docs, you know, and they know that you know what you're doing, then you might shoot that and then go back and tell them to readjust the order to a 3 view, right? Or if you don't have that rapport with them, then you might go and show them the AP and say, yeah, you don't really see that on lateral. You want me to shoot oblique, right? So communication's key. And over time, they probably will get to the point where they will just say, yeah, just go ahead and, you know, if you see something, just go ahead and shoot it. And we'll adjust the orders. All right. So calcaneus, the key to a calcaneus and imaging and determining whether or not the patient has a fracture of the calcaneus is whether or not they can perform what you need them to perform. Okay, so what I mean by that is your Achilles tendon hooks in right there. All right, so that's where your Achilles goes.
So when you dorsiflex your own foot, let's say you're trying to stretch out your calf muscles, you dorsiflex your own foot, what do you feel? You feel that stretch? Straighten your leg out and dorsiflex your foot. You feel that stretch? That's in part because that is being pulled upon, okay? So what do you need to have the patient do for a dorsoplantar projection of the calcaneus? Dorsiflex foot 90 degrees, right? So if they can perform that, then chances are it's not broken. Or if they can perform it without, great pain, some of your patients will do whatever it is you tell them to do. But if they can do that without a whole lot of pain, then probably not broken. So if it truly is broken, then they may not be able to perform that. So our angulation, if the patient can perform it, is 40 degrees. But if they can't, let's say the toes are pointed a little bit, then all you got to do is increase your angulation. Okay, so collimate down to just a little bitty area, 40 degrees phallic angulation. Your technique's going to be something similar to a foot. The difficulty in teaching technique is, and I think I've covered this before, is that I can tell you what I would shoot some person with based on my own anatomy, right? So you kind of memorize your technique based on what you would use on yourself, and then you adjust for the next person. So my average person is going to be totally different than anybody else's, right? So teaching technique is something you just got to kind of pick up in clinicals. What would I use on myself? And then, okay, is this person bigger than me, smaller than me? Adjust accordingly. So again, wedge filter would be good in this case if you were using some archaic technology. In this case, the thin end would be over the toes and the thick end would be under the heel. So the preferred lateral, again, is the same for the lateral foot. The only difference here is that your central ray is going to be about assuming you're shooting medial lateral, about an inch distal to the medial malleolus, the small focal spot size. So this demonstrates why it is that we have to change our angulation if the patient's toes are not dorsiflexed. If they're dorsiflexed, you're not going to get the superimposition of the metatarsals and the tarsal bones, but if the toes are pointed, you will. Okay. All right, so rotation, I'm not going to say that a little bit of rotation is the least of your worries. Really, that is the most important thing. But if you have a little bit of rotation side to side and your fifth or first metatarsal, the head of your first metatarsal or fifth, base of the first or fifth metatarsal is visualized, it's probably not going to be all that big of a deal. But the projection of the calcaneus should look somewhat like that. So if it's a little bit scrunched, that indicates foreshortening. So maybe the toes were pointed a little bit, but not enough to get the rest of the foot overlapped on it, right? Or if your angulation was too steep, then the calcaneus just is going to look like it's really stretched out. So I want to open this real quick. And we're not going to watch it, but we're going to kind of scroll through and take a look at some common fractures. Say we are. Try here.
Hit browse, maybe.
Yeah, there you go. Good call. All right, so I'm going to mute this guy. So Jones fracture is here. Again, it's not really an incidental finding on some of the images, but it is sometimes an unexpected finding. So a patient really twists their ankle and they may have a fracture at the base of that fifth metatarsal. So you've got three different levels of Jones fractures, and it could be a stress fracture, Jones fracture. A Vulgin fracture is where just the
tubercle breaks off, and that's what we refer to as a pseudo-Jones fracture. So, stress fractures, Jones fracture, pseudo-Jones fracture. So the way they would fix that, if it needs to be fixed, in a lot of cases they just put a boot on the patient, but if it's bad enough, if it's displaced enough, then they'll put a screw in that tubercle and just run the screw straight up the medullary canal of that metatarsal. So I think this was a case where I don't remember exactly. I mean, I'd have to go back and rewatch this, but I want to say that was a lawnmower blade hit him in 2 places. So most of the time your calcaneal fractures will be because somebody fell from a height and they landed on their feet. I knew a guy that fell out of a tree. He was a tree trimmer, and he fell out of a tree, broke his calcaneus. I knew a CRNA. I worked with him for a lot of years in surgery, and he was hanging up. So we got in a discussion like 2 weeks before this in surgery, and it was right when landscaping companies started hanging up Christmas lights. Right, they charge you to hang up Christmas lights. They come out, they do a great job, hang up Christmas lights. And they come back after Christmas, take them all down. And it costs like $1,000, right? And he's a CRNA. He was making 6 digits, and this was late 90s. It was a chunk of change. The man could afford it, and he was just adamant, I'm not paying somebody to hang up the Christmas lights. About 2 weeks later, he was hanging up his Christmas lights on a ladder in the driveway. Driveway was wet, ladder got out from under him, fell down, broke both calcanea. Both of them.
Do you think
Yeah,
he landed?
yeah. I think he would have rather paid somebody to hang his Christmas lights. So what they can do though, I don't know exactly what they would do with this one, since the fracture lines are both kind of horizontal, but they can plate and screw the calcaneus to fix it, to repair it. So other things, this is just vascular calcification of the vessels, the arteries in the foot. This one just didn't show up real well on the AP. I'm gonna go ahead and play it so we can see it. Oh, there it is. So on, again, the oblique of the lateral, the fracture line did show up. This patient has open epiphyseal plates, so it's a little bit more difficult to visualize, and sometimes your ER docs or your radiologist will ask for comparison views. Sometimes with the open growth plates, it's difficult to determine exactly whether there's a fracture there. So, and I've had doctors who wanted to see comparison views on opposite extremities to truly get a comparison, but I've also had doctors just want to see, adjacent toes in order to visualize that. So that's going to be a doctor's preference. So look like a slight avulsion there, possibly. Just not a whole lot there. So this was pretty interesting. I think the history on this guy was he shot himself in the foot, playing around with shotgun, shot himself in the foot. So any kind of gunshot to extremity, a hand or a foot, is really devastating to that extremity. It's just never going to be completely right again. Probably going to lose some bony fragments blown through the foot. So if you happen to be a gun enthusiast, just kind of take it easy. Don't put your finger on the trigger until you're ready to squeeze. But look at the great toe on this one. It's just mangled. I may have told you all this story before, but one of the funniest cases I ever had was a man and wife. It was domestic violence. I'm not saying domestic violence was funny, but this one was funny. And they got into a dispute over something, I have no idea what, but, she pulled a gun on him, and she wasn't messing around, it was 30-30, so it's, you know, it's what you refer to as an East Texas brush gun. It's not a high-powered rifle, but it's still a rifle, 30 caliber rifle, and she pulled it on him, he went to take it away from her, and she squeezed the trigger, shot him in the hand. So he used his other hand, took it away from her, cocked it, and shot her in the foot. Yeah, so they made it to the ER, and as punishment, I think, the ER doc put them both into a single bed room. So they were in separate beds, put them in a single bed room. And the guy found, you know, he realized how stupid this was and how East Texas redneck this seemed to be. And even though his hand was destroyed, he was kind of laughing about it. She found no humor in it whatsoever. I think if she'd have had the gun on her, she'd have finished the job. I'm pretty sure.
Oh my God.
So anyway, gunshots can be tragic, they can be hilarious. All right, so foot fractures. All right, so ankle, very common, kind of like what we talked about in the wrist. The most common fracture of the ankle is not really a fracture of the ankle; it's a fracture of the distal portion of the tib fib. Right. So, what you've got in your ankle, you know, you got the knots on the side, your malleolus, or some people refer to them as malleolus, but you've got those two things right there, right? So what you may have is just fracture one, and you may have a bimalleolar fracture, which breaks both of them off. You actually have a posterior malleolus and possibly even an anterior malleolus, so you can have a trimalleolar fracture. But we just don't refer to the anterior posterior as malleolus, but the medial and lateral are pretty obvious. So the problem with ankle fractures is not really the fracture itself, it's how unstable is it, right? So what you have is, you can kind of think of it as a compression sock that goes from your ankle all the way up to your knee. And it's what we refer to as a syndesmosis, and you got syndesmosis all over your body, right? So your spine has syndesmosis, is again kind of like a compression sock, and it's kind of holding everything together. And the the complication of ankle fractures is you can rip that syndesmosis. Okay, so then your ankle becomes very unstable, and they can't just put a screw in it and fix it. So what they'll have to do then is, and this is the most common orientation that I saw working in surgery, is they'll put a plate and screws on the lateral, on the fibula, and then on the tibia. If you've just broken off that medial malleolus, they'll just put a screw up into it. But what they'll also do is one or more of the screws that are going into the fibula will go all the way across the cortex of the tibia. That's to reestablish the syndesmosis. Okay, you'll hear them say that we got to put a screw across the syndesmosis. But some of your ankle fractures, you'll see that. You'll have a screw that goes all the way across, and that's because it disrupted that syndesmosis. But some of your patients too, if they twist it bad enough, then you may see bruising all the way up to the knee. Okay, so our ankle views are going to be really four. We're going to have AP and a lateral, in which lateral gives you the most consistent would be the lateral medial projection. If the patient can dorsiflex the foot for the lateral, then have them dorsiflex the foot for the lateral. If they can't, then that's okay. And then we've got two obliques. We've got a 45-degree oblique, and we've got a 15-20 degree internal. Both of them are internal obliques. The internal oblique, 15 to 20 degree internal oblique, is what we refer to as the mortise view. So what that shows us then is the joint space all the way around the talus. Okay, so it just goes up and around the talus. The 45-degree oblique is going to be steep enough that it will project the lateral malleolus without superimposition on the tibia.
Okay, so two different obliques, 45 degrees, that's specifically what we're looking for. And the 15, 20 degree, the mortise shows us the mortise joint all the way around the talus. Okay? It's still gonna have some superimposition there though. So most of your fracture is gonna be the lower third of the leg, dorsiflex of the foot. So what you're gonna see on tests in dorsiflexion of the foot on the AP is you dorsiflex the foot in order to 90 degrees in order to keep the calcaneus out of the joint space. Now, if the patient over dorsiflexes, then you can get the toes actually into the joint space. And again, there's probably nothing wrong with the patient's ankle. If you're ever doing an ankle on a patient and you walk into the room, let's say, you're doing tabletop and you pick the leg up to put it on the image receptor, have the patient pick the leg up, and you see and hear and feel the foot dislocate. All right. Most of the time, they can pick the leg up and it hurts, but it doesn't dislocate, and you certainly can't visualize it. But if you can see it, you pick the leg up and you feel a ka-thunk, and you possibly even hear it, then it's extremely unstable, and you have totally destroyed the syndesmosis. In that case, what has happened most likely is that syndesmosis is torn all the way up, and it's technically an ankle fracture, but there are no broken bones in the ankle, and that would be where you've fractured the proximal portion of the fibula. Okay, so if you have a patient like that, I've only seen it twice. If you have a patient like that, go ahead and set it down, go talk to your ER doc, and say, I think we need a leg on this patient. All right, so talk to the ER doc, ask him if you can just shoot a leg, because you're going to have to bring him back, shoot it anyway. What's better?
Put it down and walk away like you didn't do it.
Yeah, somebody else does that. Yeah, it's creepy. I tell you, you pick it up, and the foot's kind of like that, and you pick it up, and the foot just goes flop, and it's flat-footed while you got the leg up here. It's creepy. It is. But just go ahead and set it down. Go talk to your ER doc. Say, hey, can we shoot AP on the leg? And that's what we refer to as a Masseneau fracture. And it's a French spelling. I'm not going to butcher it, but it's a Masseneau fracture. You can look it up. It's spelled like a French word. So, yeah, there's a lot of vowels and an X in there. I don't know. All right, so AP of the ankle. We talked about all that, I think. 15 degrees. The 15 degrees puts our intermalleolar line parallel. That's for our joint space. 15 degree internal oblique. If you're looking at your own ankle, then the lateral malleolus is a little bit posterior to the medial, which is going to play a part in the lateral here in a minute. So what we're going to do is we're going to oblique the patient enough that those two malleoli are at equal distance from the image receptor, and that should put us at 15 degrees. 45 degree oblique is halfway lateral. So there's your mortise, and this is our 45 degree. So we've got total separation between the talus, calcaneus, distal portion of tibia. Our fibula is out there all by itself, as opposed to our mortise, we can see all the way around it. But notice we still have some superimposition there. Okay. There are fat pads to look for, anterior, posterior fat pads on the lateral. The fat pad is, remember, a fat pad is a soft tissue indicator of fracture. So you get swelling in the joint space, and you may have displacement of one or both fat pads. If you just have a strain, sometimes what you'll see, especially if you're doing, or a sprain rather, especially if you're doing bilateral, what you may see is an increased distance between the talus and the distal portion of the tibia. That's because of swelling. All right, it doesn't necessarily mean they have a fracture there. It just is because of the swelling. But the fat pads can give you an indication of that, especially that posterior fat pad takes more injury to cause it to displace. kind of like the lateral elbow, that posterior fat pad was a better indication of fracture. Almost guarantees a fracture of the distal portion of the humerus. Kind of the same thing here. If you got displacement of the posterior fat pad, that's a good indication the patient has a fracture, even if you can't see it. All right, so leg fractures. First off, once we get to these large anatomies, long anatomies, be aware that the patient could have a compound fracture. They could have been bleeding. I recommend you wear gloves with feet. Feet are nasty, right? And you don't know what's going on with the patient. I had a patient one time, and this is really a gross story, but I had a patient one time and just got an order for a foot. It was in the ER, and had no history, just foot. And she said she could walk, so let's go back to the X-ray room. So we had two. This is not at Mother Francis here. It's a different hospital. It's over in Longview. We had two X-ray rooms in the ER, and so we'll walk her down to the X-ray room, put her on the table, and I turn around and look, and there's a wet spot everywhere she stepped. Okay, no history on this patient, just a wet spot everywhere she stepped. So now I'm questioning the patient, what's going on? And turns out she was diabetic, and she had neuropathy in her foot, and so she couldn't really feel. One of two things is going on with neuropathy. Either they're numb. Oh, you're gonna go throw up, huh?
No.
Either they can't feel anything, or they're always in pain, right? So she walked down, to the X-ray department with this open sore on the bottom of her foot. So we'd have gotten her down there, in a wheelchair, on a stretcher or whatever, and without gloves on, start manipulating her foot, and then come back with nastiness, right? So put your gloves on for feet. That's a minor diversion from this, but what I've found sometimes with the long bones, especially in the tib fib, is if the patient potentially has a compound fracture or some sort of laceration, that the ER staff, nurses aides, whatever, have a tendency to clean up the patient before we get to them sometimes, right? And then you go to pick up this patient's leg, and what you find out is that they didn't move the leg to clean them up, and now your hand's full of blood, right? So wear your gloves, because you just don't know where there's a laceration or potential compound fracture. Anytime we get into a long bone that's this long, you want to support proximal and distal, right? So pick up proximal and distal to where the injury is. Wear your gloves, pick up proximal and distal. And then remembering the divergent central ray is going to cause parallax, essentially, right? Because the divergent central ray is going to project both ends away from the end of the image receptor. What you might need to do with your image receptor is turn it catty-cornered in order to make sure that you've got plenty of image receptor, right? And again, you can use the anode heel effect. You can use the anode heel effect also on the calcaneus and the foot as well. Remembering always to put the cathode end over the thicker anatomy. In this case, it would be using the anode heel effect. We put the anode over the ankle. Okay, so if you have sometimes your fracture of the tib fib is going to be pretty obvious. The patient comes in, their knee is pointing straight up at the sky, and the ankle's pointing off to the side, right? So in those cases, what you may have to do is you may have to do an AP with the knee AP and the foot lateral, and then you would shoot a cross table lateral with the foot AP and the knee lateral, right? So all you're trying to demonstrate is a fracture and the displacement of the fracture. So don't try to get your perfect textbook positioning if there's an obvious fracture. You're just not going to grab the toes and bend them up. So a lot of latitude in imaging, leg fractures. If they're truly broken, then you're just not going to get good positioning.
So if they're not though, then on the AP, you want your femoral condyles parallel to the image receptor. You want your toes pointing straight up at the sky. On the lateral, it's the exact opposite. We want our femoral condyles perpendicular. Our malleoli are going to be somewhat superimposed. They're not going to be perfectly superimposed because, again, that lateral malleolus is going to be a little bit posterior. So how we're going to evaluate our ankle and our tib fib is to look at the talar domes. Okay, so your talus, you have a tendency to it kind of looks a little like a car. You know, it's got a little hood out front and then it's got a cab, right? But that cab is kind of has an indentation in the center of it, a little bit of an indentation in the center of it. So what we're going to look for is that superimposition. All right, so on your leg, they're not going to be perfectly superimposed. On your ankle, they should be. Okay, so what we're going to look for on the ankle for rotation on your lateral is, again, the lateral malleolus and medial malleolus are not going to be perfectly superimposed. But if you have an increase in desuperimposition so that the lateral malleolus is posterior, then what you've got is your toes pointing towards the image receptor. And if, on the other hand, you've got really perfect superimposition, then what you've got is the toes elevated a little bit. That's going to be pretty common. I'd say more common to have the toes elevated, especially if they've got a complication like a Jones fracture. It's going to be real tender, right, to lay on that side. So what you might want to do is build the patient's heel up a little bit, even if it increases the OID just a little bit, build the heel up a little bit so that you don't have that rotation. For the lateral of the ankle. For the lateral of the tib fib, again, you're not going to have a perfect superimposition because of the divergence of the central ray. So AP. Notice we have superimposition proximal and distal. Lateral, we also have superimposition proximal and distal. We've already dealt with the distal superimposition. We can get a good view of that lateral malleolus with our 45-degree oblique. So we've got to do something to be able to visualize proximally. And that doesn't get to us until we get to the knee. So this is weird. All right? There's a lot of funkiness going on with this thing. All right, first off, I didn't put the third one in there.
That's two different ones.
That's two different people.
Yeah.
Okay. I thought maybe that they took this one, removed the plate, and put an IM rod in. Okay. So, you know what? Let me do this. Because I've got it. Where did I put it, though? Yeah, just looking at thumbnails on my computer, I thought it was the same person, but it's not. Okay. No. Maybe? No. I've got too many folders. Oh, you know what? Let me do this. What's profiles? No. I thought I saw it show up in my most recent. Okay, all right, well, I think we can still see what we need to see here, so we'll just skip through it. So then, what we've got here is an IM rod. Anybody had the joy of doing an IM rod in surgery?
No.
Probably the most challenging thing that you'll face in surgery. So what you're trying to do with an IM rod is, and especially on the knee, it's particularly gruesome, is they'll bend the patient's knee up acutely, and they'll cut a hole just on the anterior superior portion at the tibial plateau. And what they'll do is they'll take like an auger on a flexible screw bit type thing, and what they'll
first thing they'll do is they'll run a guide rod all the way from one end of the anatomy to the opposite end. So where you see IM rods, that's intramedullary rod, it most commonly would be in the femur, secondarily would be in the tib fib, probably third would be the humerus. So they put this guide rod down in it, and then they run that auger bit to just clean out the medullary cavity. And the purpose for the guide rod is to make sure that you're going into the bony fragments, right? So once they get it all done, then they hammer this thing in, this great big slap hammer, and it sounds like body shop, you know, bang, bang, bang. They drive it all the way down to the bottom, and then your part becomes more difficult. Can you see the way that hole is egg-shaped, kind of? The hole is not egg-shaped. The reason the hole looks egg-shaped is because the x-ray beam is not going perfectly through that hole. It's oval. So what we have to do then is to put our C-arm into like a lateral position and adjust it until those holes are perfectly round, so that the doctor knows, you know, where his bit's going. So if it's egg-shaped at all, he doesn't know exactly where to, you know, how to adjust his screw. So then he's going to drill a hole from one side to the other and then put the screws in, okay? And getting that perfect circle is kind of difficult sometimes. You got to unlock all the locks on the C-arm and adjust things until it shows up in a perfect circle. So perfect circle, center of the center of the screen, again because of the divergent central ray. If you're not in the center of the screen, then you're using the divergent central ray and you got parallax going on. So you have a perfect circle, not in the right place. So very, very tough. The interesting thing about this one is, look at the callus. Looks like it's swallowed up the fibula. It looks like it's fused together. And I wish I could bring up the lateral. Were they? Do you remember?
I think they were, because it was.
That's an enormous callus. So probably the hardest IM rod I ever did on a patient was, it was a femur. We were doing femur on this guy. The doc couldn't get the guide rod all the way down into the femur. So the fracture was maybe distal third, and he couldn't get the guide rod past the proximal third. And it turned out the guy had a fracture when he was a kid. He was put in a spica cast. You know, seen that? Where they, let's say my left femur is fractured. So the whole femur, you know, the whole leg is in a cast, and what they'll do is they'll take kind of like a broom handle, you know, cast it up and run it to the other one, the other femur, and just do a short cast on that. And it's a stabilization thing, okay? So he had a fracture, never had surgery on it, probably put him in a spica cast and let it heal. And so he had a callus that was going all the way through the medullary canal, broke it below that point, and had to drill all the way through that callus in order to get everything fixed. So he broke his femur twice, once when he was a kid and once when he was an adult. And then this one, we've got a broken plate, which you just don't see all that often. Most of the time, my experience is that if somebody breaks a bone that's got a plate in it, it's going to be right at the level of the end of a plate. You remember what that person did to
She
break
had
it?
like severe osteoporosis, and that's actually her third time to break it.
Mm.
And she broke like, she's had like bilateral hip surgeries, feet surgeries,
man,
back
bless her heart.
surgeries. She had a lot.
Yeah, a lot, huh?
Yeah.
That's hard. It's tough. Alright, so, you know, you wanna go into menopause with healthy bones, so, you know, weight-bearing exercise is plenty of calcium, because once osteoporosis starts, it's just, there's not a whole lot you can do about it. Alright, so we'll do knee, and then we'll pull up there. So, once we get to a knee, we're finally getting to a point where we're at a thickness and a KVP level that we need a grid, so 70 KVP or above, need a grid, 10 centimeters or above, need a grid. Means shoulder and knee size or above, you need a grid. So
unless you're doing a smaller pediatric patient, then you can do them top without a grid. So if you're phototiming, I really recommend tight collimation, as tight as you can get, obviously without clipping anatomy. And that is because, especially on the lateral, that is because the anatomy is going to have a hard time covering that photocell. The length of the photocell may be you might just be shooting through soft tissue in order to get to the photocell on the upper and lower portion of the photocell, which has a tendency to cut it off. So tight collimation and phototiming, maybe hit it with a +1. On your laterals, you might want to use +2 density or set a technique based on the AP. So your AP, you make an exposure on your AP, take note of what it shot, and then you can use that technique or slightly less for the lateral. So you're a little bit thicker AP than what you are lateral, so you can back down on it just a little bit. So for the AP, parallel, femoral condyle should be parallel, central ray to the apex of the patella, that's the bottom of the patella. And then your angulation, if you remember from positioning, first semester positioning, you've got 3 different angulations. So what you need to remember is 24 centimeters. And if we're above 24 centimeters, above 24 centimeters, you need a 5-degree cephalic angulation. If you're below 19 centimeters, then you need a 5-degree caudal angulation. So if you're asthenic, caudal, hypersthenic, cephalic, for everybody else, you're not going to need any kind of angulation at all. All right. So lateral, remember we've got a lateral of the knee and a lateral of the patella. If you're using a patella, or if you're shooting a patella, the bend in the knee should only be about 5 degrees, 5 to 10 degrees. If you're doing a knee, then you need 15 to 20 degrees. So it increases the volumization of the joint space. Use the air quotes because you'll see that possibly on the registry. Volumization of the joint space. If you over or under bend it, it starts to close that up. Okay? So on your lateral, there is no difference in angulation for body habits. It's always going to be a 5-degree angulation. Cephalic. And the reason for that is that if I hang this thing, let me turn it around that way. If I hang this thing like that, you look at the femoral condyles, you can see that the medial condyle is lower, if only just a little bit, is lower than the lateral condyle. Can you kind of see that? Okay. So if you shoot just straight, without any kind of angulation, what you're going to see is separation of those 2 condyles. With the angulation, then what it's going to do is it's going to project one condyle on top of the other, and you should see them, stacked on top of each other without really any significant separation between them. So, I wish I'd have added and I'm surprised you didn't add a Waldo to this.
Okay.
How did you miss that?
Because I was too busy cackling about his stupid knees.
I mean, you put a ghost on the last one. You didn't put a Waldo on this. What's missing? Patella. Patella is gone. And I wish I'd have put the report on this. Did this patient walk?
Yeah.
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 So she walked.
No, he is fine.
He is fine.
Physically, he's fine.
Yeah.
Yeah.
Okay.
Physically, he's fine.
I just have so many questions. You can see a tiny little patella over here. I don't see one there. You got these 2 great big tendons that have to have somewhere to attach.
Do they?
You would think. Maybe they're attached to each. I don't know. I need more information. How's this guy getting around?
He walks normal. He's fine.
Really?
There's no pain. That's my husband.
That's your husband?
That's my husband.
Really?
Yeah.
Okay.
He's fine physically. He walks normal, bends normal.
Really?
He can do whatever. His elbows are funky. Like he can't straighten them out all the way, so they're always kind of bent like that.
Oh, yeah.
But yeah, physically, he's fine.
Huh. Interesting. I gotta do some research on this.
And the doctor, when I took him in to get x-rays, because he had he had wrecked his work truck, and he didn't have like airbags or anything, so the dash ended up in his knees. And when I took him in there, I told him that he didn't have kneecaps, didn't have patellas, and the doctor was like, "That's not real." I was like, "Okay, cool." So we took him back to do the x-ray. My husband comes in cackling to himself because he didn't tell the tech that he didn't have kneecaps. So she's like, "Did you have surgery?" And then the doctor came in and he's like, "Well, you were right." And I was like, "Oh, imagine that." But
You ain't got no kneecaps.
he's fine. They look a little dumb, but he's fine.
Well, whatever works for him.
His
I need
kids
to
don't
know.
have him either.
His
kids don't have him either.
Really?
Yeah.
Huh. Yeah, he needs to have an MRI and report back to us and tell us how his ligaments are working. So, anyway. Then David gave us this. That's just nasty. Again, a car wreck, right?
Yeah, it was
That's a pretty good one.
Yeah. Dashboard came back and smacked it.
Yeah, I've never seen a femur that was like that.
I don't think I have either. I mean, y'all sent me some crazy stuff, which I appreciate. I guess the only thing that they could do for this patient is external fixation. Have you seen the patient since?
Yeah, no, she didn't have an external fixator.
No, I mean to repair that.
Yeah, no, because I did x-rays on her like a few days later.
Really?
Yeah, I don't know how or what they did, but her leg was just like in a like big cast.
Huh.
Yeah, I don't know what they did.
I don't know.
There wasn't any external fixators though.
Was she older?
Older, not
Older.
super old, but
Not old enough that they want to put her in a wheelchair for the rest of her life.
I don't know.
Uh,
Because we did some upstairs on her after.
Okay. So, was it anything? It doesn't look like it's compound. Anything poking through the skin, or
Yeah, it was open.
it was
when she
it
came
was
in.
it was open fracture. Okay. Okay, that's just. And we have Jose. So the reason I looked up our sesamoid bones, and I actually found that one, and it is what we refer to, or what is referred to as a fabella. Instead of patella, it's a fabella. So patients can have sesamoid bones behind the knees, and there's three different types. There's medial condyle, lateral condyle. There's also popliteal, but I assume, I just pulled that out and made the assumption. So demographics were just kind of all over the place. They said that something like 10 to 89% of the population have these on the posterior portion of the knee. All the knees I've shot, I haven't seen that many, but it did say that it's more common in Asian populations. Why, I don't know. So this was a Hamlet?
I did standing, but yeah.
You did it standing? Yeah. That means that you have done professionally one more Hamlet than I ever have. Because never done, well, I did one on myself.
She was Asian too.
She was Asian? Oh, there you go. There you go. All right. So, but yeah, when I first saw this, it just didn't look like there was a whole lot of foreshortening of either the femur or the tib fib, and I was like, that's a big intercondylar fossa. And I looked at that, but that makes more sense. It had a Hamlet on it. Very cool. And Josh with Sunrise, did you have any patient information on this one? Because
He was getting a knee replacement.
Oh yeah.
Yeah,
Okay.
that's just a pre-op.
Okay. Okay. Well, the difference in the appearance of the anterior versus the posterior portion of the knee is kind of weird. You got a distinct line of demarcation here where you've got very dense versus not quite as dense. So, anyway, so we'll pick up there next week.